Okay, I think we're going to go ahead and get started. Give it a few more seconds. All right, I am going to lock this poll. Thank you everyone for your participation. Okay, so good morning and welcome to the third of a four-part Framework for Action webinar series, Aligning Quality Measures. Can we measure what matters more efficiently? I'm Amy Etzel, Implementation Manager with the BRIE Collaborative, and on behalf of the BRIE and our partners and friends in the webinar series at the Washington Health Alliance, we're so excited that you could be here with us today for this important conversation. For those of you joining us for the first time, and as a reminder to our returning partners, this webinar series developed out of a virtual value-based care summit that the Alliance and BRIE hosted together in November of 2020. As we reflected on the summit and the conversations we all had together throughout that day in November, it became clear to us at the Alliance and the BRIE that we wanted to continue the momentum we felt from all of you and to think together about tangible steps we can all take to move beyond just kind of admiring the problems within our healthcare systems and to provide an opportunity to continue movement toward value-based and person-centered care here in Washington. So we started this webinar series in January of this year, examining the role that social determinants of health play in our systems, drawing off of Donald Berwick's keynote message from our November summit, where he reminded us that while addressing the healthcare system's inefficiencies as a priority, it cannot be our only focus. And he really challenged us to act based on a moral obligation to address the broader social issues and inequities within our systems. Our second webinar in April focused on the challenge of interoperability and how to actually achieve our goal of putting the patient at the center of care and prioritizing the needs of those patients over organizational boundaries. And then here we are now today for our third webinar. We're moving into a discussion about quality measurement and how to address the challenges of measuring what matters as efficiently as possible to accelerate value-based adoption and success here in Washington. We have a really fantastic lineup today who will speak to the how and the why of measurement, remind us to be thoughtful of unintended complexities that can arise when implementing strategies in care delivery settings, and as well, they will share some success stories to get us motivated. Starting us off is our sort of aspirational speaker of the day, Rebecca Etz, co-director of the Larry A. Green Center. Becca is a cultural anthropologist by background, which I just love as a lens to approach these issues with, where we are truly trying to find a way to put the patient at the center of care. I won't steal her thunder and say too much, but her work at the Larry A. Green Center and development of the person-centered primary care measure, a new comprehensive measure of high-value aspects of primary care, is extremely exciting. Selfishly, as a practice transformation coach and implementation nerd working with clinical sites and always thinking about how to measure progress of clinics without contributing to administrative burden and provider and staff burnout, this is really exciting and I cannot wait to learn more. My co-host, Karen Johnson, Director of Performance Improvement and Innovation at the Washington Health Alliance, will then facilitate a short Q&A for us all with Becca before moving into our second presenter, Alicia Birkmeyer. Alicia is the Executive Vice President, Chief Health Management Officer of Arkansas Blue Cross Blue Shield, and she will share some insights and success stories from her work in Arkansas, where they really did take that step further beyond admiring the problem and found a way to bring all the necessary players to the table. And she can give us some good insights as we move toward better alignment here in Washington. Karen will then facilitate another short Q&A with Alicia before moving into our local boots on the ground portion of the day. We will then be joined by someone who really needs no introduction to us all, Dorothy Teeter, former HCA director, who will share a bit of a historical perspective about the vision and reality of our own common measure set, and then lead a facilitated conversation with 3 local partners with medical expertise and their perspectives on how aligning quality measurement supports a more meaningful focus on improving care delivery. Before we begin, just a few housekeeping items of note. You are all currently on mute and will be throughout the next hour and a half. During each presentation, please feel free to write a question into the Q&A box at the bottom of your screen. Please enter questions for our speakers into this box and any technical issues into the chat box. I will be monitoring both throughout the webinar, but I will be looking primarily at the Q&A box for questions. Additionally, this webinar is being recorded and a link to the recording along with slides of today's presentations will be emailed out to you early next week. Okay, I'm now going to turn it over to Becca. Becca, let me know if you have any trouble grabbing the screen to share your slides.
Thanks. I appreciate that. It's lovely to be here today. Happy to share my thoughts with everybody, and I'm happy to answer any comments or questions people have, both during the Q&A and after, if you like. I tend to have a low threshold, so any questions are fine. What I'm going to do here is actually just move to the punchline first. I know it's difficult sometimes to pay attention to screens, especially after a year and a half of having them so prominent in our lives. So are we measuring what matters? My quick answer is no. That seems kind of flip. It's not meant to be. We have lots of measures. We are measuring lots of things that we actually really, really need. But we tend to use the wrong measures for the wrong thing. So hopefully in talking today about measuring what matters and how measures focus our attention, we can offer some adjustments to that paradigm and move us a little further along. When I think about this, I usually start with this little story of life with my mother. When I was in college, my mother sent me an article from the Harvard Law Review, and it said that rewards do not work to incentivize the behaviors that we want. And it came with a $5 bill. And she said, if you believe the article, send the money back. And knowing my mother, I intended to, but on my way to sending it out in the mail, I passed by a Starbucks, and my need for coffee was more important than I had a coffee. What I think is important about that story is even when people do what looks like the behavior we want and they get the incentive, we don't necessarily know why they did it, nor do we know where the incentive went. And so I tend to keep that in mind when we think about measures and what we do with them. So why do measures themselves matter? Well, measures are really about self-definition. And I know this is a discussion about primary care, but everybody's sitting out there. Take a minute, right? Breath in, breath out. Every single one of us gets measured every year. We get an annual review, we get some kind of report card, and we always find that process a little uncomfortable. And usually it's because the way our job is defined or our role defined is not exactly a match with what we do during the day. So we're not really quite sure how to make sense of this thing. That is just ever more present for clinicians these days in primary care. Measures are supposed to be about aspirational direction. They're supposed to tell us there's a vector, that's where good is, go that way, and show us what it means to excel in that area. They're ways of showing us how the world around us knows us, how the world around us determines what's most important, and they're a communication with a purpose. That thing we find most important, are you doing well at it or not? So when docs talk about it's a bunch of check boxes, what they're letting us know is they're not finding these things to match up with their self-definition or with any kind of aspirational direction. They're finding it to be about, we're supposed to be checking boxes and you want to know if we've checked them all. So that's a basic conversation we have to intercept, right? And it's partially about knowing how measures and motivations interact. So I talked about the $5 my mother sent me, and it's ambiguous what happens with that. It's also ambiguous when we have incentive-driven programs. I did a project once where we were trying to follow where does the money come when it goes into a system if it's turned in a really strong performance. Does it ever actually make it to the clinicians? If the clinicians get the incentive a year after the activity was done, does it actually inform their behavior? We don't have good answers for these. We also don't know that in the world of healthcare that efficiency is the same as effectiveness. In fact, in many cases, it's not. Doing something by rote, doing it very quickly, often squeezes out those spontaneous moments that provide for the most healing amount of conversation to start. So we try to steer away from that. Measures also encourage us to design by precedent. We create them based on what was before. And by doing that, we bake in all the assumptions and weaknesses we may have had in the model of what's done before. We come up with a practice. I love this building from Brazil. It looks like a building. I know it's a building, but it's not necessarily I want to go. It's not a place I want to go to get my care. It's not the place most people want to go. That's what it's like to create a building out of patchwork and precedent. We want something that looks more like Frank Lloyd Wright, right? We want falling water. We want the Stradivarius of instruments. We want something different than this. So how do we do that? Well, first, I think we have to confront what I think is the triple threat to the triple aim. And yes, I picked that on purpose to be catchy because I'm wanting to make sure you stay awake, but also because I really believe in this. This threat has left us somewhere in the middle of lost and very lost. And I think it's not hard to find our way out, but we need to help each other. So the first of the threats is accountability that undermines value. Accountability can be really good and important and necessary, but it's taken us down a strange path lately. It's actually served to confine responsibility for population health rather than encourage promotion of that. So we need to figure out why that happened and how we work against it. We have measures that actually have failed to evaluate work. They measure what we know how to measure, but that's not the same thing as what we know to be important. And third, we have health data that is connected to payment. So when you connect health data to payment, it is necessarily informed by how practices need to stay solvent and how access to care needs to be maintained for patients. It becomes a political document and not the subjective health one. And all three of those things interfere with how we deliver care. So what does that look like in reality? What might I say? Well, if we look at population health and measures of population health, I think we all know what we care about. It turns out that our measures don't encourage that. So measures that are about the rates of how many people, what percentage of people got a vaccine, or how many vaccines we gave out in a week, or were they offered a pneumonia vaccine, regardless of whether they actually took it or not. This does not feel like care. This feels like being on a treadmill, and it's actually kind of demoralizing, and it pulls energy out and detaches us from our work. When we talk about population health, what we're really caring about is really solid and rigorous information management that allows us to mine our data so that we can use experiences of healings that are informed by communities and context and maintain both a macro and a micro view, right? So we can look at the large picture and be proactive in how we take care of our patients. That's what we want to encourage when we talk about population health. Did I ask a patient if they wanted the Pneumovax or not? That doesn't encourage the same thing. How do we make some adjustments? Well, first I look towards the recent NASEM report on primary care, and I look at these 4 terms that we're all familiar with, and I think about what they really mean to us. Quality. Quality is an essence, right? It's actually an internal thing. But when we talk about it with each other, it's the degree to which something meets expectations. And we know that because it allows us to compare. We can't know what quality is of one person doing one kind of thing, but if we see lots of people doing the similar thing, we can compare them and see who's an outlier and who's staying with the pack and who seems to be doing a little bit more. That's what quality really is for us in medical care. Performance is how well something is done. It's the actions we take. We usually look at performance and how well it's going to lead towards quality, how well it meets up with expectations. That's value. Value is what we think is beneficial, and we determine it's beneficial because we share an agreement about expectations and norms. The expectations of patients, of clinicians, of payers, and the professional norms that guide our work. That's value. That's what we have to keep in mind. Accountability to value, then, is accountability to how well performance, our actions, are aligned with expectations and professional norms. That's what it's supposed to be about. That's what we want measures to fill. It's what it means to be fit for purpose. That is, how do we enable high quality care? It's really easy. It's one part measures aligned with the purpose and value of primary care, and one part the use to which those measures are put. So you can have the best measure in the world, but when you let it out in the wild and people use it for other things, you don't necessarily get to control how they use it, and it can go down a very wrong path. What measures are not, and what we all need to remember, is that they are not instruments for corrective action. They're not meant to be used to punish people for not meeting a standards. They're meant to show us aspiration, a direction, a vector we should go when we want to excel. They are not meant to be proof of services rendered or a return on an investment. There are other things we can use for that. Quality, as determined through measures, is not meant to be targets and whether or not we have achieved a target. There's a wonderful theorist, Goodhart, who says that any measure that becomes a target ceases to be a good measure. It's what we in the measurement world refer to all the time. And that's true. A measure that becomes a target encourages us to find that ends by any means necessary. That's not professional behavior. That's by any means necessary. What we hope to encourage is a world in which people use the very best behaviors that they can display in order to reach their aspirational potential. Measures are communication with a purpose about quality and accountability, aligned with expectations and professional norms, and they should be shared across stakeholders. It's that sharing part that we fall down on the most. So what do I do with this? Well, we created a measure. I never thought I was going to create a measure. I would have told you I never would. As an anthropologist, we don't believe there's any one thing that 320 million people in the world can agree on. So a national measure seems kind of crazy, but it is actually possible. What we developed is the person-centered primary care measure, the PCPCM. It was endorsed earlier this month by NQF, and the proposed rule for measures from CMS for 2022 just came out, and the measure's on that. So it should be part of CMS and the MIPS program for 2022. When we created this measure, we knew that there were certain problems we were facing. The first is that there were too many measures in primary care and they were too burdensome. Now, if you're not familiar with the world of primary care, you may not realize this, but most measures are disease dependent. They focus on diseases and disease pathways. 80% of primary care has nothing to do with diseases. It happens before any diagnosis is made. So right away, measures that are specific to diseases and disease pathways miss 80% of the work that's done. They also aren't aligned with what the people practicing primary care feel is most important and what the needs are of the people who go there. So to correct these issues, we sought to find out what was most important. We did a crowdsourcing activity. We did it with patients, hundreds of patients, 425 patients, 515 clinicians, and 100 purchasers. By purchasers, I mean people who were responsible for purchasing the health plans for their companies. What you see on the right here is the kind of scatter graph that makes a quantitative theorist shudder. It's the kind of thing only a qualitative person like me would put together, because I put it together with some purpose in mind. The first thing I did was I aligned all the responses of people to our open-ended questions across the bottom, all 10,000 comments received. Then on the side, I used as codes current measures as well as current paradigms for understanding primary care. I very, very purposely, with intent, put all the current measures grouped together in the middle because I wanted to be able to highlight exactly what we see. It is a tunnel vision. It captures only one part of primary care in the best possible way, maybe 38% of primary care, which means that 62% in the best possible light, 62% of what we do remains in the dark. It is not examined at all. So what we need is not just to have fewer measures. We can get more efficient at that tunnel vision, but we also absolutely have to be able to see the rest of the spectrum. These are the things that both clinicians, patients, and purchasers agree is most important to primary care. Why are we not paying attention to that? So after doing that crowdsourcing, we analyzed the 10,000 comments we had, and we came up with 18 quality areas that were of importance to everybody involved. We then said, okay, it's just an academic exercise if you just get what people feel is important. We need to make it fit for purpose. It's got to be operational. It's got to be that payers can use it and employers can use it, otherwise it doesn't matter. So we held a national conference named after Barbara Starfield, a real muse in the world. And this national conference was held in DC among 80 of the top researchers, academics, practitioners, patients, policymakers, internal medicine, family medicine, pediatrics, pharmacy, social work, behavioral health, occupational therapy. If you could find it in primary care, it's sitting in that room right there. And I'm showing you the room so that you can see we had them captured at tables. This was a 2.5-day conference in which there were no talking heads. We made them work. And what I told them all is you were invited to this room because of your expertise and because you are in position to make decisions. But your day jobs keep you from doing what's right. So I'm going to ask you to park your day jobs at the door. We're going to spend the next 2.5 days figuring out what's right, and then leave it to me to figure out how to make it work. And they really did. It was unheard of. It was really fantastic. We had digital recorders on every table. You can see we had note takers at every table. What we came up with is when you take the 18 areas that everybody else loved, and you think about what's operational, there were 11 of them that we could put into play right away. So we created an instrument, one question for each of the 11 things that people cared about. It had to be an easy to understand question. It had to have good face validity, had to have a simple scale. We list these items and then we ask for your endorsement. You either definitely agree, mostly agree, somewhat, or not at all. There are a couple of vocabulary things here that I want to point out to you right away. First, you'll notice if you do any measure work that this is different than other measures. It says my. It doesn't say this practice makes it easy for patients to get care. It says my practice makes it easy for me to get care. When you ask questions in this way, you keep them at the personal level. You prevent an alienation that can happen between the person answering the question and what they're answering it about. So that was a very important aspect that we included. The second is, you see it says doctor. And I get questions a lot of times, but what about nurse practitioners? What about physician assistants? Are people going to be confused about what they're responding to? And the answer is no. Out of 10,000 comments, not a single one used anything but doctor. It turns out that's the way people use the term when they're speaking colloquially, and they know it stands in for their care provider, whatever certification that might be. The last is the question about, my doctor and I have been through a lot together, and people have a lot of concern about this when they wonder, well, if you're new to the practice, or if I just started my practice new, is there some way I'm going to be dinged by that? In those cases, I say, that's the old thinking. That's thinking of the measure as a target. It's not a target. This is simply an aspiration, and it's used for comparison, not as an object reality all by itself. Nobody gets a perfect score on this one, nor should they. I'd be really worried about a doctor for whom every patient says they've been through a lot together. So we took this then, and I point out that this seems very different than any measure we have, and it seems an almost impossible thing to implement. It really isn't. We implemented it during April and May of the pandemic last year. It took 5 weeks to not only onboard clinicians, but to get data from their patients. It was really, really easy to do. Everybody loved it. And so I brought up these two folks for a real reason. The field of primary care is incredibly young. We tend to see the way things are and think that's the way it's always been, and there's no way that we can change it. The guy on the left there, Carr White, is somebody you could touch, and he actually created the term primary care. That's how new it is to us. His mentee was Larry Green. I named my center after him. He still talks to me. But this is a touchable past, which means it's a changeable future. So the measure measures what matters in primary care, which is relational knowing, that you have somebody worthy of your trust, that sees the wholeness of your biography, handles the majority of your needs, and helps you to integrate your story so that you can truly heal. So that's about the person-centered primary care measure. This is our team. It's fairly big, our funders, to which we are truly indebted. And I thank you for your time.
And Becca, we thank you as well. We've got a couple of questions here in the chat. One is really a comment and a compliment. Said, loving this so far, I'm very awake. So you've been effective there. And asked a little, the comment was really about the quadruple threat. You mentioned the triple threat, the quadruple threat of physician burnout. and the sheer volume of measurement that happens in healthcare, much of which, as we know, is duplicative and focused on process. So I think the question is sort of related to some thoughts that I have around, a lot of the people in the audience today represent jobs, teams, and maybe even whole organizations that do measurement in that tunnel vision lane that you point out, that you say we can be more efficient. And that's something we're going to be talking more about later. But how do we create a glide path from here to there? And how do we think about the way we've used that? And this is another question that came from Christine Staley, as targets. If a measure is not a target, how do we develop that? And how do we think about that moving forward?
Sure. So it's hard to develop measures not as targets. It's the way we use them. Actually, they're not developed that way, but it is the way we use them. We need to not teach people that less than perfect is somehow less than good in terms of the measures. Backing up to sort of start with the first question and move forward, the quadruple aim is, the fourth part of the quadruple aim is about joy in practice. And this is a really big thing. And it's even bigger during the pandemic, but honestly, it was big before the pandemic. What we find is that this measure that we've introduced is actually a salve for burnout. There is a moral injury that has been done here. The world, as we see it as clinicians and patients, with the care we find most important is not paid attention to. And the things we find least important about our jobs, the ways to document our activities during the day, is the thing we get measured on. It's at odds with what we find to be most important. So it's demoralizing to be graded by things that don't feel important to you and to have the things that you do feel important to be ignored. What we found is in the areas where we use this measure, it actually creates some joy in practice. It returns professionalism and internal motivation to the job. The glide path here is really important, and it's actually pretty simple. A lot of the measures we have, we absolutely need. They are clinical measures, and they tell us whether we are doing right for different clinical conditions. God bless them, we need more of them, as many as we can possibly get, to understand measures that guide our professional judgment. A1C, blood pressure, is important. Those are not the same as performance measures and shouldn't be connected to payment. We forgot that when we learned how to document blood pressure, the purpose was not to become the best document of blood pressure ever. It was to prevent MIs. That's the goal. So we need to capture that information. We need to look at a population level across those important clinical measures to understand how we're delivering our care. But performance is about shared expectations in line with professional norms, and we are not paying any attention to that. So the glide path here is about developing the measures that matter, paying for those, and allowing clinical judgment to be followed up by the professions intended to understand that judgment to their fullest.
Thank you for that. It really flips the script and helps us think about things, I think, really differently. There's two more questions in here. In the interest of time, I'm going to remind everybody we have one of the great silver linings of Zoom and platforms like this is that we can answer in writing as well. So there's a couple questions in here about, how is this different than CAHPS? Some of these questions seem very similar. And how do we deal with the response rate issue? So Rebecca, I'm going to say a hearty thank you to you, ask you if you'd be willing to answer those questions in the chat. And I'm going to ask Amy to bring up a quick poll that we have here as we transition to our next speaker, Alicia Birkemeyer. So the poll here, and if you aren't familiar with the whole Zoom deal, you can resize this window. When measuring quality, what matters most to you and your organizations? We've got the traditional categories here, sort of thinking about where we are today of cost, access, quality, or HEDIS, which are many of those process measures, clinical measures that we're talking about, and then patient experience. So Becca, thank you very much. We're going to let this go as Alicia joins us here. Thank you, Alicia. So by way of introduction, we heard Alicia's with Arkansas Blue Cross and Blue Shield. I had the good fortune to interact with Alicia really closely and directly through my work at Blue Cross and Blue Shield of Kansas City prior to my arrival here in Washington State on medical home program development work that we were doing in Kansas City. And when we became part of Comprehensive Primary Care Plus, one of the CMMI primary care innovation models, Alicia met Alicia through the National Payer Network, and she was good enough to say, well, come on down and join us in Arkansas for our regional collaboration that we do with the folks in Oklahoma. And so much great learning there, and I'm glad to have her here with us. Before you start, Alicia, I think we're going to have Amy end the poll, or maybe I can do that. I think I can do that. And I'm going to share the results here. And we still seem to think that quality is really important. I would love to have the traditional HEDIS measures are very important, followed closely by patient experience. And it would be really, really interesting to be able to have the conversation about why quality matters. Just like you were talking about, we don't know what people do with incentives and why they do what they do. Why does quality matter? Why does HEDIS measures matter today? Why do they matter? Is it because it's tied to payment or because they are inherently important? So I think that's a really important question that you've caused us to think about, Becca. And with that, I'm turning to Alicia. Thank you, Alicia. Alicia, we can't hear you yet.
Very good. Can you hear me now, Karen?
Yes, we can. Thank you very much. And I think you're sharing your screen. Very good. Thank you.
Very good. Excellent. Well, it's a joy and pleasure to be here with you today. Karen offered me the opportunity to share a little bit about our Arkansas story. And I'll have to admit, I enjoy talking about our story. It's been a journey, I think, talking about this process for Arkansas for both value and quality throughout the years. And I want to start with a disclaimer. I feel very privileged to be speaking with you today. We don't have it all solved, and I look forward to learning from everyone, every opportunity that I can receive. So I'll go through our story, happy to answer any questions or elaborate on any of the opportunities that we can do. So today, what I'm going to talk a little bit about is something, as Karen mentioned, we have been really big into believing that to change healthcare here in Arkansas, it's really got to be a public and a private collaboration. We have to do it together to support the providers, the changes, the needs. It has to be a collaboration. I'll talk a little bit more about that in a few minutes. Just going to talk about some of the quality programs and initiatives that we've been working on. Karen asked me to participate on this webinar. It really forced me to kind of sit back and take a look in history. The time goes so quickly when you're having fun. And so we've had a lot of fun in Arkansas and had a lot of opportunity, and we'll talk a little bit more about each of these programs coming up here. So why Arkansas started in this? Some of you may be in the same situation, but the health status in Arkansas is very poor. We needed improvements. I've been with Arkansas Blue Cross and Blue Shield for 32 years. And I can tell you that the system, the healthcare system where we think we've made improvements, is still hard to navigate. When I've had the opportunity, just in the past year to navigate the system with a family member, even though I've done it for 32 years, it's still, sometimes you find yourself going, how do I get this fixed? Or how do I figure this out? Or why can't this be easier? And so that's certainly something we really want to look at and continue to improve in the future. Also, the healthcare spending, the growth of the cost is just unsustainable and has been a focus for all of us. And really the belief for us and the experiences that we've had is working through a public and private collaboration. That's when we can make a difference. So as I mentioned, Medicaid and private insurers, I'm going to go back to, it was probably in 2012, early 12, that at that time our Governor Beebe went to the head of Medicaid and had the same similar conversation they had with our CEO back in 2012, that very thing I discussed with you. It's not sustainable. We've got to make some changes. We've got to make some improvements. And so we began to sit down with the multi-payer group and discuss the challenges that we were sharing, the challenges we were working through. What we learned very quickly is our challenges were similar. We may just call them different things and may have different definitions a little bit, but the goal ultimately was truly to improve healthcare, to make a better experience for our Kansans, and also, as we mentioned earlier, how do we reduce some of that burden on the providers? So that's certainly been our journey. We've been looking at this through quality opportunities and also patient outcomes. And so on this next slide here, you'll see throughout the time, this journey started in 2012, we've had a multitude of different payers that we collaborate with. As Karen mentioned, we also had a multi-state that we still to this day on a quarterly basis all come together. We roll up our sleeves. We come into a room with no cell phones or computers and talk about healthcare, improvement of quality opportunities, aligning metrics and measures. How do we support these practices across our states and improve care? You'll also see that we've had some self-funded customers. Walmart's been at the table with us from the beginning to really try to address some of these challenges and improve these opportunities. And it's been very important because, as you know, the more collaboration and support you can give the practice, not only from just a financial perspective, but also when you align your efforts, it really helps them tremendously. So I'm going to spend the majority of my presentation time just walking through this slide here. It is our story of Arkansas Payment Improvement Initiatives is what we call it. And I'm going to start actually a little bit to the, I'm going to start over and not go really in the chronological time, but start with, first of all, Arkansas was a state innovation model, one of the first grants. We received $42 million over 42 months that the state received. And one of the things that I think I should have declared at the beginning is because we've been working in this multi-payer arrangement for so long, back to 2012, we've all kind of become a community. So sometimes I find myself in the presenting, it's Arkansas story, not just Arkansas Blue Cross. So you'll notice that I'll kind of talk really more about our state. Back in 2012, I'll never forget when we went for CPC Classic to Washington. At that time, one of the medical directors had told me, said, Alicia, I can't travel to Washington. So when you go to Washington, you are Arkansas Blue Cross, but you're also Qual Choice representative as well. So I think that gives a little bit of the flavor of how we, over this time, we've gone through births and deaths and other things, that we've built the relationship that even though there are things we compete on, we still are working for the overall good together. So that innovation grant, that was $42 million over 42 months that supported these other things we'll talk about here. The first effort of multi-payers was really our episodes of care. And with the episodes of care starting in 2012, that was an effort and a project that we spent significant amount of time every week having multiple teams through Medicaid, Blue Cross, Qual Choice, and the payer, sitting together and trying to understand what are our challenges? How do we eliminate the variation? How do we give the reporting back to the providers so they can see the variation and the differences to make improvements? How do we give them data that is usable to make a difference, to improve that quality of care for the members? And so there are 22 episodes of care that we worked on together throughout the time. One of the things that what you'll learn is when you do make progress, sometimes you do get a push backwards sometimes, and you have to just understand and roll with that. But one of the things with the episodes of care is we did benefit and win through that process of eliminating variation, because in certain parts of Arkansas, a knee replacement could be 3 times what it was in another area. So transparency, data, information led to better quality across our state. There were some specialties that, as you know, winners and losers, we had some legislation passed around our episodes of care that prevented a downside risk into those episodes of care. So it ended up has turned now to more just a data and information there. But the transparency certainly has made a difference, and we continue today to see the variation has been cleaned up on those episodes. Moving then to the patient-centered medical home, Arkansas Blue Cross and Blue Shield specifically started a patient-centered medical home pilot in 2010. Probably many of you were also at that time going, what is a patient-centered medical home? What does it work? What does it look like? And that's where we were. So we chose to take a look into this and piloted a program. And I will have to admit, naively in 2010, I thought it was going to be very easy, that you just take this claims data, you take your clinical data, you put it together, and you have this phenomenal actionable report for the clinicians to use. I sit here today, unfortunately, in 2021 and say we're still trying to pull those reports and success together. There's no perfect way, because one of the things is I learned is we try to track quality, we try to track these reports. If you put garbage into an EHR, then you're going to get garbage out. And so do all the providers put the same field the same way? And how do you compare and how do you look? So data will continually to be, I think, something we work with. But one of the things repeatedly that I heard through that pilot is, Blue Cross, this is great, you're doing this. However, you can't pay me enough to transform my whole practice. So about the time we were hearing this message wrapping up our pilot, there was an opportunity for the Comprehensive Primary Care Initiative that rolled out. To me, that was one of those opportunities that, well, if everybody pays this way, then guess what? We can help change care. So very fortunately, because of our work in the episodes of care, we in 2 weeks' time had all the payers at the table, and our application to CMS was uniform, with the exception of payment. So we were very fortunate to be one of the first states as a comprehensive primary care program. And I think that's one of the first times that we all started sitting at a table weekly. And sometimes it was more than once a week, because what we were trying to define and understand is, how do we align the program? How do we support these practices? And how do we give them the tools and information that they need to truly transform their practices? At that time, we actually had 130 practices that applied for participation in the Comprehensive Primary Care Initiative. CMS chose 60 of those. So what we knew at that point is there were a lot of practices in our state that were interested in looking at practice transformation and value-based care, but they had not been selected. And many of those were the pediatricians, which are the very ones that had started early in the patient-centered medical home world. So the state came together, and we also supported in 2014 a patient-centered medical home that was Medicaid focused and more of a pediatric focus, and supplemented. It ran similarly to the CPC, but it was for practices that maybe had not been chosen for that early pilot. The other piece of positive legislation we had was, as we were offering up and starting up our exchange here, the ACA in Arkansas, there was some legislation that passed that basically said to sell as a qualified health plan on our market, you had to support the patient-centered medical home program in our state. So that certainly allowed an equal field, and all payers were supporting it that were on the exchange to those practices. And then what we, those were running very well. We were seeing improvements. We were seeing reduction in ER and readmissions, better medication. We have practice coaches that go out and work with the practices. The multi-payer group, along with CMS, coordinated those efforts. We hold the regular training sessions, educational opportunities. It's back prior to COVID, when we were all sitting in a conference room together, learning from one another, and it was moving very well. Then we go into a CPC Classic or CPC, and the initial expired. We were able to be chosen as one of the Comprehensive Primary Care Plus markets. And then as of last year, we actually started our Primary Care First program to partner along with CMS as well. What that has done, as partnering with CMS, has really brought some funding and some support to our practices here in Arkansas that has been just very critical for their transformation and their support. This last piece I have here is just to talk about, one of the things Karen really wanted me to talk about is how we started in quality alignment and measurement. And I bring this as a reminder here that when we started CPC Classic, we applied and we did not find out that we were chosen until August. We chose for a start date of October the 1st. And you're thinking, wow, that's kind of crazy to get everything set up. And so what we really looked is we took upon an attitude of what can we do? And we would try to figure out, it might not be the best or most sophisticated or most elegant way to do something, but we were going to do it one way or another. And so, for example, on the quality metrics for CPC, we took CMS's measures, and then at the table identified from a commercial perspective what's our must-haves, from a pediatric, what is our must-haves, And what are we all measuring today? So what is doable? How are you handling it? So we started out actually very simple and created a spreadsheet. It was a spreadsheet, data information that we all payers agreed to submit to the practices on those same measures so they could do it. Then we moved to an Excel spreadsheet so they could all correlate and pull it together on their end, even though we didn't have a data aggregator at that time. Then what we heard from the practices is, well, now we want drill down. So I think my message here is that you can start simple, you can grow it. Where we're all at today is we have portals that are almost real time that gets their measures and their metrics and their information to them. We, to this day, still from a multi-payer group, meet weekly. We coordinate the efforts. We really try to reduce that burden on the providers, and we have seen really good. I think that with this team, the Milbank report was shared to show that there is great success. We contracted with a healthcare economist that did a return on investment, and things are positive. And as I mentioned, we will continue to grow and develop and learn, but I appreciate the opportunity to present our story to you today.
Alicia, thank you so much. It's great to hear from you, and it's great to go back and remember all of the great things that you've done in the state of Arkansas. I think one of the things that you're doing sort of flew under the radar there when you talked about the practices coming together and actually sharing a practice coach with all of the different providers that you were working with in concert with Medicare. And someone asks here in the question Q&A, did you involve your state QIO, QIN? Is there a role for others in this initiative? But can you talk about sort of how that sort of relationship with the providers was facilitated by the collaboration that you're doing, and what you feel like that meant for the important outcomes that you've seen? And we will put the Milbank paper that you referenced in the chat or in the Q&A or available to all the participants today.
Absolutely. So it's dependent over time with the funding that the QIO was involved, which was a contract through our Arkansas Medicaid program. And so those resources were there, and then we have our resources. So they actually have a team. And I think that's one of the things, practice transformation coaches just aren't just out there everywhere. And so to have that skill set and that talent, we did training coordination through those. All payers, bring your practice transformation coaches to the table. We're going to make sure we're working towards the same guidelines. And we also did some divide and conquer. So when the numbers were smaller, we're up on our practice coaches today internally. We have 10 coaches. They have around 30 to 40 practices they're accountable for. And we've even moved in the Blue Cross perspective that their incentives are based upon the performance of their practices. So they're bought into that improvement too. But we really spent time, and we continue to work together. With the Arkansas Medicaid, the funding has run out, and so those coaches and that work from the state has really fallen to our teams, and that's where they've kind of picked it up. But there was a lot of coordination and collaboration throughout the early days.
So there are a couple of questions here, Alicia, about the fact that you may have a significant market share in the Arkansas market, and that may be part of your sort of success story. Can you speak to sort of the role that played and what that means in a market like Washington State that is not dominated by a single payer, but really has many successful payers in the market?
Yeah, I would. I will tell you throughout the time we've had various payers and encourage the payers at the table. It is a large percent. If you look at Medicare, Medicaid, Blue Cross, that's a pretty large percent, but we have continued to ask and for the other payers to be at the table. And I think, to me, it doesn't really matter so much as your market share, but what is the collaboration? What is the uniform story that you're telling to those practices is in the support. So where we hear from the appreciation of the practices is when we can align metrics and measures, and we're consistent about those through all the payers. It doesn't really matter who's the dominant or not. You're being consistent, and it lowers their burden. So I think that's the important piece. And I think working together, finding those areas and opportunities that you can collaborate, that's where everyone wins.
Yeah, and we'll hear more about that when we get to in just a moment here, our boots on the ground panel, what that looks like and feels like from the provider perspective. Last question here that we have time for right now. You started out with an patient-centered medical home program. Question about, did you use the NCQA definition, and maybe how has that evolved over time?
Oh, that's a wonderful question, because I will tell you, early on in our patient-centered medical home pilot, our goal was to get them NCQA recognition, and they did a phenomenal job. But then then we pulled that back a little bit, because the early NCQA, prior to recent changes that they made, there were some opportunities, I think some check boxes, things have improved over time. So it's certainly a tool that is available, and we did reward early on. Today, some of the rules or the requirements of participation are very similar to NCQA, and some of the practices still have NCQA, but it's not a requirement any longer of our program to participate for those primary care first, CPC plus, or patient-centered medical home.
Yeah. Well, thank you very much. We have one other really great question here around the HEDIS measures it uses targets in your contracts. We'll try to get that in writing as well. Alicia, thank you. Becca, thank you. You can see we have some new boxes that have popped up on the screen, or like folks walking into the room. And at this point, I'm going to turn to Dorothy Teeter, who, as Amy said at the top, really requires no introduction, other than I will just simply say, as a relatively new arrival in Washington State, she's a gold mine of information. I'm so grateful to have her sharing some of that with us here today as we look at, what our opportunities are in Washington around common and aligned measurement and the benefit of a common measure set. So Dorothy, thank you.
Well, thanks so much. And it's been really, really fun to listen to the conversation to date, to this morning, and to be able to participate with the panel that I'm looking forward to talking with in just a few minutes. I'm going to spend a couple minutes before we kick off the most important part of this, which is the quote unquote boots on the ground. I don't know if it's boots or what it is, but boots on the ground folks that are really in the provider world, having to receive and experience and manage all of the measures that we all cook up and hopefully cook up with our clinicians. But before we start, in just a few minutes, I'm going to talk about the common measure set in Washington State. Like Arkansas, Washington State received a State Innovation Models grant. And as part of that, the legislature in Washington State produced a bill, or passed a bill, House Bill 2572, I can still remember the number of it, that was around some of the policies and the new sets of requirements, really, that they wanted to put in place as part of the kind of foundation and the sense of direction for the state's healthcare systems. So as part of that, they did mandate in 2013-2014 session a common measure set. Then I'm going to go through some of the intent of that legislation, and then I'm going to talk about some of the key areas of measurement, and then step back and go, here is the intent. It's now 2021. Where are we from sort of where I sit? And then we're going to turn it over to our panel to talk about it from the perspective of the folks that are actually providing care and overseeing that. So the intent of the legislation around the common measure set was, first of all, to create a committee that had a multidisciplinary approach with providers, patients, insurers, labor, policymakers, measurement gurus, researchers, the whole crew, to sit around a table and come up with a set of measures that were much smaller than the hundreds that people were experiencing at that time. Now, of course, people still feel like they're having to deal with hundreds of measures, but I'm going to say hopefully that's condensed somewhat. We came up with different categories of measures, and the intent of these were kind of twofold. One was to really focus on the performance of the healthcare system itself, the delivery system, around cost, or around quality mostly, and secondly, around population health measures. So it was really to listen to hue and cry of the providers going, you know what, every single contract we have with a plan, it's got different measures. There's different measures of blood sugar. There's different measures for hypertension. There's some have measures for hypertension, some don't. It's just this kind of big mess. And so the idea was to come up with a common set that could be used in part to measure population health over time, but in part to embed within healthcare contracts between plans, purchasers, and providers to really push forward on the other policy push from the legislature, which was value-based purchasing. So the hope was to create a little more efficiency, and because there are fewer measures that were very well delineated, and then to delineate further which ones make sense to use in contracts and which are ones that we should just be watching directionally for how we're doing in terms of population health improvement. The second thing that was really important to the legislature was to evolve the measures over time. So the fear was you'd come up with a set of measures and they get stuck in place. So this committee's job, it's still an ongoing committee, was to meet periodically to say, what are some new things that we should be putting in here? Does this measure still make sense? And to continue to wrestle with new ideas and the evolution that, of course, we see in the health system. So the other recognition I think that the legislature had was that, as was mentioned earlier, Washington State has lots of payers, lots of delivery systems. It's pretty fragmented and kind of a lot of uniform distribution of business across a lot of health plans. So how do you pull everybody together and see if we can get somewhere given that fragmentation? The point about value-based purchasing, that was a pretty new term at that time, although now it feels a little old and we need to come up with a new refreshed term. But it was really to make sure that when we were using the dollars that we had as purchasers, and they focused a lot on the healthcare authority because we were purchasing care for about a third of the state at the time, that we were ensuring that we were using those taxpayer dollars in this case to pursue more standardized care, not standardized care, using standardized measures so that we could look to see how all those dollars were being used. But secondarily, we wanted measures that were trusted by the providers. So as we went through to come up with these common measures, we had people saying, that is a commonly used measure. It makes no sense clinically. Can we not use that one? So we went through hundreds of measures and came up with about 40 some, I think, at the end, which still, of course, everybody thinks is too many. So it was really and the idea was to get all the plans and the purchasers together to agree that they would all embed the same measures in contracts with delivery systems, so the delivery systems could decrease all of the noise and pick a few things, and it didn't matter who the payer was, they were going to take care of all patients the same way. Now, mind you, clinicians, that any self-respecting clinician is going to say, which they should, I don't really care in certain sense who the payer is. I'm going to do what's right for this patient, whether or not there's a embedded measure in a contract or not. They don't see all of that. But the idea was take all that noise away and help the providers with one set of measures that could, again, evolve over time. The other piece of this that was really important to the legislature, and I think to the state, was that it was a transparent report that was produced from these common measures on a routine basis to say, how are we doing as a state? Here are the measures, here's what we're putting in place. How are we doing as a state, down almost to the practice level in some places when it was possible to measure against those measures? And so the Washington Health Alliance has partnered with the Healthcare Authority to produce that report on a routine basis. So that is the transparency for a patient. It had to be easy to use data and reporting so that any normal person, not just a healthcare nerd, could understand the information that was in those reports. So that kind of concept of standardized measures, get rid of unwarranted variation, make sure the measures make sense clinically, that they can be used for both health improvement from a delivery and population health, and then report it out and evolve it over time were some of those sort of key constructs. I can still remember, and in the legislation, it said that the director of the Healthcare Authority needed to chair this committee. Of course, I wrangled the executive director of the Alliance, Washington Health Alliance, to co-chair, because it was a big job. I can remember thinking, well, this should be fairly straightforward. And then walking into this room with, with this committee that is all leaning in to make sure we get the right measures, going, oh, this is not easy stuff. But miraculously, or maybe not, it's just that Washington Health community is pretty tight in terms of their view of how things should be. We came up fairly rapidly. It maybe took 6 or 9 months with an initial set of common measures. Quickly, I'm just going to talk about the categories themselves. One was around primary care. A lot there was access and patient experience, which kind of fits in with the original discussion we had this morning about even a new measure for patient-centered primary care. Immunizations and screening was also a part of that. So it was sort of to keep people healthy, make sure people could get into care. Behavioral health became more, over those 6 years since 2014, more of an area of focus. It's an example of the evolution of the measure set. And then chronic care, the usual suspects with diabetes, hypertension, et cetera, asthma, making sure that, again, it was not only what the levels of blood sugar were for diabetes, but were eye exams or the group visits if possible. Just all of the kind of normal accepted measures that for chronic care that we could come up with. And then inpatient care was really focused on patient safety and readmissions. I would say that you can listen to this list, and I'll make sure to make this comment that we did not put any homegrown measures into this information, into this data set initially, just because it was so important to make sure that everybody could use the standardized measures that were nationally vetted. So that was really tough because there were so many creative measures, especially in the area of behavioral health, that were much more homegrown at the time. And so we did some experimenting with that along the way, and that still goes on to this day. But we wouldn't put something in that measure set that you couldn't, if it was designed for putting into contract, it had to be measured in a uniform way across everybody's systems. And then the population health piece was really important, and I'll just make an editorial comment that I think this will probably become even more important over time. There were measures of the rates of obesity, the level of obesity, substance use among youth, and the things that the public health department, tobacco use, rates of opioid use, all of those, urgent and emergent issues around population health were also part of the population health measures, not to be used in contract, but to help align, again, everybody towards one set of goals. So just really fast, I know, but the intent, I think, let me just go through to create an evolving measure set. I would say that is still in place. That measure set continues to evolve. The embedding the common measure set in all purchasing contracts, I'd say that's very mixed. The state contracts, because of the legislation requiring that those are in all of those, it's been really tough to get all health plans purchasers to align around what that set of measures is. So that's mixed. There's some progress in that area, though. If you look at the kind of the road to value-based purchasing in the state, we're moving well along that road. The publicly reported, easy to understand reports, I'd say those are in place. Just look at the community checkup and other reports from the Health Alliance. Reducing unwarranted variation in performance. That's something I want to engage with our panelists around. Can you use these measures and the results from those for ongoing improvement within your organizations? I think there's, again, mix. It's because we're fragmented systems still. Improving the efficiency and consistency of measurement, even though it feels very difficult and maybe not as much progress as we want. I think we have made progress in getting some of the noise out of the measures. And that has to continue. And again, a question for our panelists. And then evolving the measures over time. Again, there's been some of that evolution with behavioral health, opioids, using patient reported outcomes, trying to look to see if that's something that we can start to embed. And then an area there that I don't think we have done nearly enough with, because it's an emerging issue, is the area of how to measure equity, access, quality, and care itself. So ongoing challenges, I think, are, I'm throwing these out for you guys to disagree with me on the panel that's coming up. Universal adoption of those measures in contracts across this, universal, by that I mean this across the state. Continued work to simplify the measures where possible. I think that's something that's ongoing progress. Getting the patient voice more embedded in some of the measures that we have, and then ongoing issues around equity. So that's a real quick nutshell of kind of where Washington State started and where it's come. I think the gift in Washington State is the bipartisan support for the work to continue to innovate and measure and in value. So we don't have a lot of cultural fights around whether we should do it or not. It's more how it's the results, and what is it, are we in fact measuring what matters? So with that, I'm going to open this up to our panel, and I see everybody here. We have, maybe you can just wave when I introduce you. DC Dugdale is a medical director, value-based care at UW-Medicine. Drew Oliveira is the Senior Medical Director of Population Health, Cambia Solutions, which is part of Regents Blue Shield. And then Tony Butchery, which is a family physician, Cascade Medical in Leavenworth. So we've got a mix of people that have lots of experience. And I'm hoping, when we talked earlier when we were preparing for this, that we want really candid conversation. What's working, what isn't, what are people's wishes and for the future. So I have a set of questions here that we wanted to throw out. But before I do that, I'm going to ask you each to just comment for 3 or 4 minutes on from your perspective on what you see the progress today. And I outlined it from my perspective and how we're going in terms of aligning measures for success and achieving the cost and the quality and health improvements that we are all work for every single day. So Drew, why don't we start with you?
Great. Hey, thanks, Dorothy. I hope you can hear me okay.
Yeah.
I think I'll probably come to this in a couple of different points of view. One as a family physician, but also someone who's worked for health plans for the last 16 years. And I'll take that sort of lean since we've got practicing physicians also on the panel. I would say that the measure set has been very, I think it's been thoughtful in the direction that it's been developed. I think the measures are not anything that I think are very controversial. They are very primary care focused, so they, I would say, leave the specialty care, folks off the hook. And I love what Rebecca said earlier, that a lot of times measures are check boxes. We go through the checkbox, make sure it's done. Thank you very much. But is it aspirational? Does it change practice, et cetera? And I think when you look at the results in Washington, especially on the commercial plans, we're not at the 50th percentile for most of these measures when you look at national metrics, and we're not really moving a lot of our measures above that 50th percentile. So I think there's certainly an opportunity there. I think the other piece is that we don't really have measures that are very efficiency based. So are they going to really save money, impact the cost of care, et cetera? They're very primary care based in general, and which are all good ones. And we have big gaps in there related to access to care. We could have stronger measures in terms of behavioral health. And then I would say, from a payer standpoint, our ability to accommodate those measures, because we're a local payer as Regents Blue Shield, it's a little bit easier for us. I think all the payers have gotten better at having measures that are more consistent. But we also have health systems that say, look, I'm not going to do 40 measures or 120 measures or whatever the number we want to create. We're going to work on these 5 or 10 or 15, and that's what we want to work on. And each system in a value-based contract may choose different measures that they want to focus on because they maybe already have achieved, success in some measures. And we have to have that flexibility. Although as payers, we tend to be a little slow in terms of our ability to flex with contracts year over year, and that's on us. And I'll stop and maybe pass it over to either Tony or DC.
Oh, Tony, why don't you go next?
Okay, I'll assume that you can hear me. So a few quick comments. I think that, one, and this has been alluded to, but, and I'll admit my home computer printer is really not all that fast, but when I asked it to print the Washington State Common Measure Set, I was kind of shocked at how long that thing was working in like 9 pages of kind of fine tuned. So it does seem like there are just too many measures for us to kind of sift through. I think that's one easy observation to make. And I want to pause and just say thanks to Rebecca, Alicia, and Dorothy for your comments, and to the Healthcare Authority and the Health Alliance for sponsoring this. Rebecca referenced the NASEM report, and they spent some time looking at measures. And I think one of the things that they really said is we don't really have a quality measure set that really supports the development of highly accessible, highly advanced team-based primary care. And that really should, at least from my standpoint, be the goal. And I'll say quickly, I'm chairing a primary care investment task force, so I've got that perspective, but mostly I'm a small town family physician. That's what I've always done. And so I think, realizing that we don't, even on a national level, there's not really this agreed upon way to do this. It's a recognition that, people are complicated. Taking care of people is really complicated. It's hard. And to measure that in a way that really supports doing that better over time, really, I think we're finding it's just not easy. And in many ways, we really are at a stage where we're sort of winging it and just looking around and seeing what seems to work. And so it needs to be a flexible, ongoing process. And I think we all come at it from different perspectives as well, providers and plans, and everybody has a little different perspective on it. So I think we should all remember to be kind of kind with each other and build some patience and nice communication into the system. And I think leading into kind of the last thing I would like to say is, I think we should have, as best we can, that common goal. And to reiterate, as we look at any specific measure, and sometimes it's hard to know, but does it really support the development of that accessible, high quality, team-based primary care? That's really what we want from these measures. And no one measure is going to do that holistically, but does it support integrated care delivery? Does it support improved access for patients? Does it support an improved patient experience, improved provider experience? As Dorothy so aptly mentioned, does it support improved health equity? I think these are all just important considerations as we look at this. And at the very least, we should try not to include measures that have the potential to hurt the process of delivering good patient care, because that happens a lot too, frankly. And having too many measures is one way to do that. Having measures that aren't standardized is another. Anything that increases our administrative burden, that causes more work for us in a way that doesn't really support our practices, that's really kind of hurting what we're all trying to accomplish here. And that should be kept in mind. And I think that, as I look through those measures, I kind of put a couple of asterisks on, here's some measures I think might actually hurt things along the way. And I'm happy if we have time in the questions, I'm happy to specify those. And some that I think actually in a way that might surprise folks have the potential to push this along in a constructive direction. One common feature, and the ones that kind of caught my eye, like, that one makes me nervous, are the ones that really try to micromanage my practice, to try to build in practice expectations that might frankly not always align with best patient care. And I think we need to be careful about that possibility as well. So I'll leave it there and be happy to join the conversation a bit later.
Thanks so much, Tony, for the caution about unintended consequences of the measures too. DC, how about from your perspective?
Sure. Thank you, everybody, for allowing me to talk at this forum. First, with respect to the alignment question, our experience has been that alignment of measures has improved. Whether the common measure set development is responsible for part or a large part of that is hard to say, but even just stating that that's something that we want to do, I suspect has influenced things in a positive way. There's still variations that occur. We have in the neighborhood of 12 value-based contracts within UW-Medicine. And there are differences across those contracts, but they mostly have more in common than they have different. Still, even in the details, there can be differences that may not affect the measurement process, but affect how we translate that information to practitioners. So for example, there's several different measures that rely on the A1C, and we can see variations in that, even though the A1C is at the core of it. In terms of the challenges, there still remain some challenges, and these challenges do create, I would say, unwanted variation in how we handle all this. Population choice is a significant problem. For understandable reasons, individual payers are interested in the quality performance for their individual members. But that's, as has already been somewhat stated here, that's really not how the clinicians see it. It's certainly not how the health systems see it. And having to devote energy to coning down a population multiple different times for each payer is counterproductive, in my opinion. Attribution of patient populations, or many of the plans use an attribution method, and that is an imperfect process. I'm sure it's better than it used to be, but it's an imperfect process. And we would favor, in fact, strongly favor incentives that are stronger for driving patients to PCP choice, so that attribution through a claims-based algorithm doesn't have to be the way in which it's done. What does that mean? Well, in terms of benefit design or other incentives to create those. I practice primary care internal medicine, and basically live and breathe primary care with my clinical hat on. So I support, and our health system would support, things that move patients that direction. The method of assessment is also problematic at times. Payment claims, of course, those are fine, but using that to then become the way in which quality is assessed, I think that works well in some situations. So for example, mammography, I think that's a reasonably concrete and simple approach, but it doesn't work so well in other situations. And I would advocate for payers to get access to electronic medical records more directly. I suspect the payers would be interested in that too. There's many different safeguards that would have to be built into that, but I think the notion of using a claims process that was not designed for it, was designed for payment as a way of calculating quality brings in various problems. Some of you on the call probably know about what are called CPT Category 2 codes, and that's another refinement in terms of the claims-based method of calculating quality. It works reasonably well for some things like blood pressure. It doesn't work so well for other things where the results are not synchronous with the transmission of the claim. And a lot of effort can be put into creating all that in a way that honestly is simply not, I think, resources well spent. The final thing I'll say is that some of the measures, and I don't necessarily say if I can point the finger at the common measure set on this, but some quality measures in which we work are somewhat overly prescriptive about what they want people to do. Sometimes that comes down to requirements in the claims process. So for example, an advanced care planning conversation, one of the codes used to document that states that it's 15 minutes. Well, some of those conversations don't take 15 minutes. If it takes less time than that, you're kind of faced with a choice of how to handle it as a clinician. But ultimately, measures that are overly prescriptive in that nature or must be prescriptive, but then are adapted to this kind of quality measurement, I think, again, can at best or create lots of extra effort, and kind of channeling Tony's comments could actually lead practitioners to do things that honestly aren't the most logical things from a clinical standpoint. So I'll stop there, and of course glad to answer questions as they come up in the rest of the session.
Well, I really appreciate those comments. I found myself listening to all three of you going, man, this is just not perfect science, is it? it's the biggest challenge when you're working with people and systems and incomplete data and good intentions all around. I guess that's the good thing, to try to make the progress that we want. I found myself thinking, geez, if only we could take what we've learned now and leapfrog over to the next generation where people have access to clinical data. I mean, imagine what the world that we would be in, it would be make a lot more sense. We have several questions. I'm gonna skip over a couple because I think you guys have answered it. But I'm wondering about, and Tony, I think I'll start with you on this one. What do you think we could do to take that? Maybe it's a two-part question. One is there are 40 some measures within that, say, common measure set, and you guys are all really pointing to the fact that subsets of those make more sense with different populations, et cetera. So we can't like do all of them for everybody. But how would you work together? What would be a process or a way that you would see working towards even deeper alignment, not necessarily about these are the measures, but the ways in which we could use those measures over time and get all parties to align, whether it's the state purchaser, the health plans purchasers, the employers, Medicare, whatever it is. What are some ways that you think we could even do a better job of getting that alignment? Is it starting with the delivery system and moving up? I mean, how would you suggest moving forward to get even more efficiency and alignment about meaningful measures?
Yeah, thanks, Dorothy. I appreciate that. And I'm curious what others think about this as well. I think that there are a lot of good conversations and webinars, like we're holding now. And as I participate in some of these work groups that bring together primary care and policymakers and representatives of insurers and stuff, and we start just communicating and getting to know each other, I think that's a huge step. I think the idea of flexibility is an important one, because a lot of times we don't really know if this is going to help us or hurt us until we've just kind of tried it for a while. And the ability to reevaluate and redirect as we need to is an important one. I think everybody kind of agreeing on as best we can on what our goal is. And I'd sure lobby for our goal here, again, is to redesign our system. So we just take better care of people up front to primary care and resource us appropriately to do that. And if we all have our eye on the ball and are looking at the same thing, I think that helps a great deal. And the other thing I think I would say, the last thing, and then I want to hear from others, is I think a lot of times we're just kind of worried that we're making this investment and our primary focus is on documenting that investment pays off. And I think that I understand that, but as a practicing primary care physician, I think a lot of times I really wish there was more trust that practicing primary care physicians, the allied health professionals that we work with, the psychologists and the social workers and our nurses, we're all here to do our job as best we can. And I think sometimes I feel like everybody just really wants to make sure I'm doing my job right. And a lot of measures are designed with that in mind, rather than actually supporting the care. And it's a subtle distinction, but I can tell sometimes that, geez, you're spending a lot of time and resources building in layers of administration, just making sure I'm using these resources appropriately, rather than actually letting me use those resources appropriately, if that makes sense. So
yeah, that's a really, really, really important point. Drew, and then DC on that same question.
Yeah, I think maybe I'll just kind of respond a little bit to what Tony was saying, because I think that's, it's important to have the right measures that actually offer value. And, I think you're right that some of those measures, saying, hey, you're just, checking my work, and not necessarily providing, support to do the work that needs to be done. And some of those things like, that are maybe outside of both primary care and the payer community and even the employer community. Things like access to good behavioral health therapists. We're number 45 or 46 in the country in terms of access for behavioral health. I mean, that's pretty poor. And so what else has to be brought to bear so folks like Tony can have an integrated primary care behavioral health practice when maybe that therapist isn't even available? That would be something that we can, bring to help close whatever that gap is. And it shouldn't all be on the primary care doc to do it. I think what, DC was talking about with attribution, I think is a real issue. I mean, we've got our employers in the, at least from the commercial plans, they don't want to steer their members to, one health system or another. And frankly, I think they should. I think some do better than others. And that would help, accelerate those systems to, do a better job. And I would much rather see, people assigned to a DC so that they know where they're going to get care. They have a usual source. They know where to go. They're not, running around when they're ill to try to figure out where that, where they should get care. I think that would be very helpful. But that's going to take employers making that decision. It's going to be plan designs from the payer side, but then having resources available, to help really shore up and support that. If we do that, I think we can actually have the resources then funneled back into those systems that are really going to be managing that care and make it certainly a more sustainable and higher quality experience for the members.
Yeah, thank you for that. You guys are all three making me think that instead of focusing in contract on each one of these small measures, maybe there is an overall picture of how that's going, but the onus on purchasers and plans to really work on what's causing the biggest pain and greatest pain in primary care. Access to behavioral health is a perfect example. Attribution is another perfect example. There are these things that maybe instead of focusing more on evolving a measure set, we should be focusing more on supporting primary care in the ways that they tell us they need the help.
Right.
Yeah.
Dorothy, I'd even add, you think about different primary care type practices. University of Washington, you have access to all the specialists in the world. You can, get your patient, funneled into to see someone pretty easily. If you're in rural practice, how do you get that consultation for that member quickly, not 6 months or 8 months from now, where they have to travel 200 miles to get that care? How do you leverage technology better that will support, a more rapid consultation electronically or otherwise?
Yeah, really, really important. DC, your thoughts on?
Yeah, thanks. And actually, I really like kind of the last few sentences that you said, Dorothy, but I'm going to add just some brief process and then content on the measurement question. With respect to process, I think joining forces between patients, practitioners, and the payer purchaser community, as has been done by the healthcare authorities' work the past couple of years, I think is the way to get to probably an optimized measure set. Mm-hmm. I'm not quite sure what all the problems with the approach might be, but ultimately, I do think the healthcare authority has done and is probably positioned right to lead that. With respect to content, I would, and I'm reiterating some of what was said already, I would reduce the number of measures. I would put greater emphasis on patient experience. And I do think this issue of not having a good measure for team-based care is an important one. Perhaps the measure that was talked about earlier in this session, is the way to go on that. It sounded like it was measuring parts of team-based care to me. So, and if it's going to be implemented next year, we'll get some experience with it.
Yeah. Okay. Well, I see that we're close to out of time here. Amy, I'm going to ask you, should I ask our lightning round question in 30 seconds, or should you go ahead and do that for the whole audience?
You go ahead and do it, and then I'll just say to the audience that you're welcome to enter in your own answer to the upcoming question into the chat.
Well, before I do that, I just want to say thank you so much to our panelists. I know all of you and your great wisdom that you've earned through your careers over time and continue to contribute. And the more we listen to smart people like you and wise people like you, the better off we're all going to be. So really, really appreciate your thoughts. I know you made me think very differently from what I came into this panel thinking that might be really cool next steps. Okay, so this is a question for everyone. What do you envision 5 years from now if we are successful in leveraging common measures for overall improvement. And they should just type stuff in, Amy, is that right?
Yes, so we welcome the panel to voice your answers, and then the audience, we'd love to hear your thoughts in the chat box. We will be saving the chat log and potentially reaching out if there are any brilliant ideas that come forth.
Okay, so you guys have like, you know, 1 sentence each.
Yeah.
So
You want me to go first? I'll go first.
Go.
So 5 years from now, we'll have 6 measures or less, and we will have agreed that creating the strongest possible primary care system, including assignment, will be the way to get there.
Awesome. Okay. Tony.
5 years from now, we'll have doubled the amount of resources going into primary care such that every patient in Washington has access to high quality primary care, and the measure set will support that.
Excellent. And Drew, you get the last word.
In 5 years, we will see health systems move from being seeing primary care as feeders to their specialists to having primary care as the center of their delivery system.
Okay, there we've got it, you guys. That's what we need. 5 years from now, when we have this panel, that's where we're going to be.
This is being recorded, so we're going to hold you to it. Well, thank you everyone for being part of this discussion, and for our audience, thank you for participating along the way. And Dorothy, thank you so much for facilitating this really important discussion. I just wanted to put a plug in for our 4th and final Framework for Action webinar series happening on October 14th from 10 to 11:30. And we have highlighted our lined up speakers and participants. I will be sending out this save the date slide along with the slides that go along with Alicia and Becca's presentations, as well as our links to sign up for the Washington Health Alliance and BREAK Collaborative listservs, where the registration links will be originating from. So again, thank you everyone, and we truly hope to see you in October to continue our conversation around implementing aligned payment models. Have a great afternoon, everyone. Thank you.